Good morning. So it's appropriate that a talk on CML follows the one on transplantation, because at one time CML was either the first or second leading cause of transplants, but we rarely do them anymore in the modern era, since we've had TKI therapies for the last 25 years now. Shown here are my disclosures. We're not really going to talk about investigational agents today, but rather address some of the remaining challenges. For newly diagnosed patients, it's clearly important to identify what the goals of an individual patient might be beyond survival, whether they're really a candidate for achieving a treatment-free remission. We'll look at the approved frontline therapies, of which there are 5 drugs available, and 1 additional drug now approved in the second line. We'll talk about the importance of addressing toxicities, particularly with regard to patient adherence to taking the medicine and the impact on quality of life. We'll talk about the increasing interest in achieving treatment-free remission and what that strategy is about. And finally talk about asciminib, which is the newest of the CML drugs that's commercially available. Shown on this slide are a number of the previously published large randomized trials looking at the development of these TKIs over the last 2 decades. Regardless of frontline therapy, overall survival now is greater than 90%, not only from the initial benefit of frontline therapy, but also the ability to salvage or rescue patients either from intolerance or from resistance. We still use the European Leukemia Net recommendations for monitoring the milestones or guideposts in terms of response. Optimal response is pretty straightforward. Most patients, in fact, do follow this steady decline in their BCR-ABL transcript levels. Warning is shown in the yellow column. These patients require closer attention, but many of these patients, even if they don't reach low levels of transcripts over time, do in fact have quite good survival. In contrast, those in the failure column need to be evaluated for the development of resistance. And in the right-hand side, you see some of the acquired mutations in the ATP binding site of BCR-ABL that interfere with the binding of TKIs. And it's worth noting that a number of mutations now have been identified in the myristoyl pocket, which interferes with the binding of asciminib. A number of academic medical centers are now routinely doing NGS evaluation for newly diagnosed chronic phase patients. It's fairly routine in more advanced phase patients when they're seen. But we're finding that some of these patients in the BCR-ABL positive clone have also acquired other pathogenic mutations. The graph on the left shows that ASXL1, which is shown in the red boxes at the top, is the most common mutation that's seen. And in the histogram on the right, it does appear to have an impact on the achievement of major molecular response. So if you can't see the labels, the green bar are patients with an ASXL1 mutation, lagging behind those in the purple bar, who are those with CML without an ASXL1 mutation, with achievement of MMR at 12 months, 18 months, and 24 months. They do seem to lag behind. There'll be a presentation, I think, at the EHA, suggesting that ASXL1 mutation is associated with the acquisition of acquired BCR-ABL mutations. So why discontinue tyrosine kinase inhibitor therapy? What's the benefit of this strategy? Well, importantly, to avoid chronic toxicities. particularly the vascular toxicity, which has been noted in several of these TKIs, avoid the late complications, and also reduce costs. Shown here are the most common side effects from TKIs in CML. Both those occur early with the use of these drugs and those that seem to emerge later. This whole class of effect of drugs is associated with fatigue. That tends to be a more common complaint among younger patients, but it's often present. There's also asymptomatic lipase elevation, but rarely is there pancreatitis. So lipase elevation by itself is not necessarily a reason to switch TKIs. Some of these drugs have idiosyncratic toxicities, but vascular events does appear to be a class effect of most of these Abl kinase inhibitors. We're not sure yet about asciminib, whether vascular complications will emerge over time. The greatest chance for successful TKI discontinuation appears to be in the 50% of patients who become eligible for this strategy. In general, there are patients who are still on first-line therapy or have switched to second-line therapy because of intolerance, but not because of resistance. They tend to have low-risk SOCL or ELTS scores at diagnosis, even though they may have been on TKI therapy for 5 years or longer, and have undetectable disease. Somehow their initial score seems to follow them along and does seem to impact the likelihood of a successful TKI discontinuation. Certainly no prior treatment failure has been a consistent feature in those who were successful. And then the duration of TKI therapy should be somewhere in the neighborhood of 5 years, 4 to 5 years, with deep molecular responses of MR4, MR4.5, lasting at least 2 or 3 years, and durable. We'll talk now about asciminib and its novel mechanism of action. Here in this diagram, you can see that the 5 other TKI inhibitors that we have all bind to the ATP binding site and inactivate the enzymatic activity of BCR-ABL through that mechanism. Alternatively, asciminib binds to the myristoyl pocket, changing the conformation of the enzyme and locking it into an inactive isoform. The ASC4FIRST trial was a head-to-head study comparing asciminib versus all of the standard of care TKIs in newly diagnosed patients with CML. The initial results were published in the New England Journal in September, and I'll show you the updated data from the ASH presentation with 96-week follow-up. It's important to spend a minute, I think, on the design of this trial to understand how it was constructed. These were newly diagnosed chronic phase CML patients, no prior TKI exposure. And prior to registration randomization, the treating physician had to declare what they would ordinarily recommend in terms of frontline treatment for this patient among the 4 available frontline treatments: imatinib, dasatinib, nilotinib, or bosutinib. Patients were then randomized to either get asciminib or to get the investigator-selected TKI. So it was a 1-to-1 randomization resulting in a group who received asciminib, but you can see that half of those patients fell into what was called the imatinib stratum, the other half into the second-generation TKI stratum, and then the standard of care arm were the investigator-selected TKIs, again, according to the 2 strata. Primary endpoint was the major molecular response rate at 48 weeks, with asciminib versus all of the investigator-selected TKIs. There was a second primary endpoint of MMR at 48 weeks, just looking at the imatinib strata and comparing asciminib versus the use of imatinib. Randomization stratification worked well to give appropriate study groups. If you compare the red boxes with the green boxes, you'll see that there was an appropriate tendency of treating physicians to give imatinib to patients who were older or had higher cardiovascular risk factors compared to using a second-generation drug. Alternatively, patients who had a high ELTS score tended to have second-generation drugs selected for them. So a reasonable assessment of standard therapies. These are the results presented at ASH, showing that the cumulative incidence of MMR continues to be higher with asciminib than with all of the investigator-selected TKIs. The MMR rate at 48 weeks was 66.5% with asciminib, increasing to 80% at 96 weeks. And the all investigator-selected TKIs, 46% had an MMR at 48 weeks and 62% at 96 weeks. The curves do not appear to be catching up with each other. Deep molecular responses were also measured at 96 weeks and were higher with asciminib overall and also across the two strata. So looking at these histograms starting from the left in the green bars, asciminib achieved a MR4 response in about 48% of patients compared to 27.5% for the investigator-selected TKIs. Similarly, the MR 4.5 rate was higher in the asciminib group. In the middle histogram is shown just the patients who were pre-selected for imatinib and then either received asciminib or imatinib. And the differences here in terms of deep molecular response were even greater, as you might expect. And in the right-hand curve is the deep molecular response rate for the second-generation TKI pre-selected group who either received asciminib or nilotinib, dasatinib, or bosutinib. There's no statistical significant difference here between these, but numerically the asciminib group seemed to put these patients into deeper remissions quickly as well. This forest plot shows that the MMR rates at week 96 were higher with asciminib than with all of the investigator-selected TKIs across all the demographic and prognostic subgroups. The ELTS score, sex, race, and ethnicity, and I should say this was a global study, and 45% of these subjects were Asian. Also true in the age category and the cardiovascular risk category by the Framingham score. All seem to favor asciminib in terms of MMR rate. Safety and tolerability continue to be more favorable with asciminib, shown in the left, grade 3 or greater adverse events. Asciminib's in the green bars, imatinib in the light blue, and second-generation TKIs in the dark blue. There was also a benefit to asciminib for AEs leading to discontinuation, shown in the middle graph, and in the right-hand side, AEs leading to dose adjustment or interruption was also less common with asciminib than with imatinib or the second-generation TKIs. So conclusions from this ask for first trial was that asciminib continues to demonstrate superior efficacy versus all investigator-selected TKIs, that the deep molecular response rates at week 96 remained higher with asciminib, but whether this will lead to a higher percentage of successful TFR is uncertain, and it'll be important to follow these patients over a longer period of time. Asciminib's safety and tolerability profile continues to be better than that of imatinib and the second-generation TKIs, and consistent with its previously known safety profile. The frequency of arterial occlusive events and mutations remains to be determined, so we'll be watching for those. Now, that's not the only frontline asciminib trial that has been conducted. This was a report at ASH and already published now in Blood in November from the Australian frontline asciminib trial called ASCEND, CML. Here, patients were treated in a dose of asciminib of either 40 milligrams twice a day or 80 milligrams once a day, but they were allowed to increase their dose to double it to 80 milligrams twice a day if they were slow to meet their milestones. You can see in the left-hand graph, the red curve at the top is the MMR rate steadily going up. The middle curve is the MR4 response, and the dotted curve at the lower curve is the MR 4.5. This has a median follow-up of 21 months. 82 of the 101 patients are still taking asciminib. Progression-free survival shown over on the right-hand side. There was one patient who developed lymphoid blast crisis while receiving asciminib and expired. So the take-home points are to design treatment around the patient's goals. To avoid resistance or recurrence, you want to ensure daily dosing of TKI therapy. This means managing and minimizing side effects to improve adherence, and to monitor these patients every 3 months, at least over the first couple of years. Make sure they're taking their drug and that they're responding appropriately according to a quantitative RT-PCR assay, which is pretty well standardized and widely available now. Consider prospective discontinuation for those patients who have been on TKI therapy for 5 years, particularly if they had an initial low risk score at diagnosis and they've been in a durable, deep molecular remission lasting a couple of years. And we need to wait for longer follow-up for the results of the asciminib trials to know what its appropriate position is in the treatment of CML. I'll stop at that point. Thanks for your attention.